It's my absolute pleasure to introduce Juliette Knowles from Stanford University. She both sees patients and studies LGS and rare epilepsies in the lab because she's a dynamo, and she is one of our LGS Foundation grantees. We have two of them speaking today, but we're really excited to hear about the project she's working on, where she's looking at the evolution from infantile spasms to Lennox-Gastaut syndrome in the population of patients who are in their learning health system. So Juliette, I can't wait to hear more. Come on up.
All right. Hi, everybody. Can you hear me okay? Great. Well, it is my absolute honor to be here speaking to you today. So I want to thank the LGS Foundation and all of you for this opportunity to tell you a little bit about new research in which we are using another big data set, a new data set, which is called the Pediatric Epilepsy Learning Health System, or PELS, to try to identify risk factors for LGS progression. And this is collaborative work that I could not do without the help of Dr. Zach Grinspan, who is at Cornell. And Dr. Grinspan is the founder and initiator of PELS, and he now runs this very large national database. And as Tracy indicated, this is new research, brand new research, just funded earlier this year by the LGS Foundation. Thank you very much. And so today, my hope is to give you a roadmap of what we are going to accomplish with this approach. And then I hope that I'll come back in a couple of years and show you the results. So, as many of you already know, LGS is a progressive disorder that commonly evolves from antecedent, so occurring before early life epilepsy. But this is not a light switch that just flips and then you have LGS. LGS evolves from earlier epilepsy on average over 1 to 2 years. 1 to 2 years is a substantial length of time in which we might have the opportunity to intervene and prevent LGS. So why don't we have preventative treatment regimens? Why don't we just bring in the LGS prevention regimen? Well, a major reason is that we can't reliably predict which children will or will not go on to develop LGS, so we don't know which ones we should be treating. So if we could identify key factors that put children at particular risk of developing LGS, then we could really focus on those high-risk children, and we could do clinical trials for potential preventative treatment. Well, there is a form of epilepsy, which some of you might be familiar with, that has a very high rate of progression to LGS. This is infantile epileptic spasms syndrome. And this high rate of infantile spasms progression to LGS is an opportunity for us to really follow those kids and figure out what causes or what puts some kids at risk for evolving to LGS. And I realize that we have kind of a mix in the audience. We have some seasoned physicians in the audience who have treated and taken care of many children with infantile spasms. We may have families that have been personally affected by infantile spasms, but some of you might not know what this is. So I'm just going to go over basics. So as the name of the syndrome implies, this syndrome is really defined by one seizure type, epileptic spasms, that have their onset in the first year or two of life. And the EEG on the top left there shows what the seizures look like on the EEG. The bottom few lines where the arrows are, you can see there are quick 1 to 2 second muscle activation, that is the spasm. And then concurrent with that on the upper traces is the brain activity that goes along with those movements. And so there's a sort of a big high amplitude slow wave that's sort of diffusely present, and following that there's this electrodecrement or flattening out of the EEG. And you can see that it's happening over and over, and these spasms do happen in clusters as shown on that EEG. But the seizures are really just the tip of the iceberg. Along with the seizures, there is developmental delay, plateau, or regression, and consistent with the brain not working quite right in this syndrome, the background EEG, even between the seizures, is abnormal. So on the bottom EEG there, you can see a characteristic EEG signature of infantile spasms, which is hypsarrhythmia, where there's sort of high amplitude abnormal activity of the background brain activity with very frequent epileptiform discharges. And just like LGS, this is a syndrome that can have many causes: structural changes to the brain, genetic etiologies, or metabolic causes, for example. And this idea of looking at children with infantile epileptic spasm syndrome to understand what leads to LGS progression is not new. Other people have looked at this, but they've looked at it at their own institution typically, so with smaller groups of patients. So I'm showing here a summary of the results from 2 single institution studies where they were able to look at around 100 children with infantile epileptic spasm syndrome. And there they found about a 30 to 50% rate of progression. So 30 to 50% of those kids that had infantile spasms later developed Lennox-Gastaut syndrome. And they found in their different data sets different factors that seemed to either increase or decrease the risk of going on to get LGS. In one study, the causes of the infantile spasms seem to be a major determinant of whether or not the child would get LGS. And in another study, the major determinant identified was how the spasms were treated, so which medication was used. So if we could somehow pool all the data from these institutions around the country and look at it all together, maybe with that large number of patients, we could do an even better job of figuring out which factors are really important, which ones should we be paying attention in terms of LGS progression. Well, now there is a way to do that, and this is the Pediatric Epilepsy Learning Health System, or PELS, that I mentioned earlier. This is a relatively new database that contains harmonized, searchable medical records for around 500,000 children with history of seizures or epilepsy from 20 academic medical centers and growing around the United States. And what do I mean by harmonized? Well, harmonized just means that the clinical data in this database are organized into standardized formats, so we can put them all together and study them together. So, for example, in this table, I'm showing the number of new infantile spasms cases over a 7-year period between 2011 and 2018. And this is just a subset of the PELS institutions that we've been able to look at so far, but you can see that that already brings us to nearly 900 cases of infantile spasms. So a very large group that we're starting with already. So we have this big group of infantile spasms cases, and now we can pull out the kids that went on to develop LGS and figure out what happened, right? Well, there are obstacles, and Dr. Lamb touched on this very articulately. So, one might reasonably say, well, just look at the children in that database that ultimately were given the diagnosis code for LGS. But prior studies have demonstrated that up to 80% of children that really do meet criteria for LGS don't get this diagnosis code. And I think merits a whole separate study of why not and what are the consequences of that. But this is just not a reliable way to identify children with LGS at this point. So then you might say, well, okay, let's just search for the diagnostic criteria for LGS, such as those that were put forth by the International League Against Epilepsy in 2022. And these criteria include multiple seizure types, including tonic seizures, an abnormal EEG with generalized paroxysmal fast activity and slow spike and wave, developmental delay, childhood onset of the epilepsy, and typically drug-resistant epilepsy. But even then, that doesn't reliably identify the kids with LGS, because when physicians document in the medical record they often don't use these buzzwords, that we need, like tonic seizures. They might describe the seizure without actually calling it a tonic seizure. Or they might describe the EEG without using the specific term GPFA. So I can tell you this from experience because I've now compiled a database of all the children that were treated for LGS at my home institution of Stanford. And I couldn't identify them using these methods. I had to actually go through and painstakingly review the chart of each and every child to really accurately determine which ones had LGS. But we can't feasibly do that for nearly 1,000 records. So what can we do? Well, as Dr. Lamb mentioned, we also are proposing the development of computable phenotypes. And as Dr. Lamb explained, really what a computable phenotype is just a definition of a disease based on a collection of search terms that enables automated and accurate identification of children with LGS. So Dr. Greenspan and I have created a number of computable phenotypes, and they're shown here in the table. So these are organized from most stringent to sort of least stringent. So the most stringent computable phenotype is likely LGS. So here they have to have the ICD-10 diagnostic code for LGS. They have to have been treated with a medication that is typically used relatively specifically for LGS. And they need to have developmental delay. They have to have all of those things. And then a less specific or stringent computable phenotype includes intractable epilepsy plus all of those other things. And then the least stringent computable phenotype is just intractable epilepsy, the combination of that and developmental delay. So when we take these preliminary computable phenotypes or search terms and apply them to just 1 year of PELS dataset cases, just 1 year, these computable phenotypes identify nearly 700 individuals with the most stringent, that meet the most stringent criteria, and almost 3,000 that meet the least stringent criteria. So this is looking quite promising as a strategy to build one of the largest data sets to date of children with LGS that might actually give us some novel insights and better understanding. And when we take that data set of all of the children with infantile spasms that I showed you earlier from multiple institutions around the country, and we apply these same computable phenotypes or LGS search terms, we find that around 30 to 50% of the children with infantile spasms meet those criteria. And that's also encouraging because, as I mentioned earlier, previous studies have already demonstrated that the rate of progression to LGS in infantile spasms is 30 to 50%. So this is encouraging that we are on the right track here. All right, so I've told you about these tools that we're using. How are we going to actually use these tools to figure out, what are the most important risk factors for progression to LGS? Well, our first step is going to be to optimize and validate those computable phenotype search terms. We want to really make sure that those are accurately identifying cases of LGS. And we're going to do that with painstaking detailed chart review on a subset of these. Once we have those search terms and we're very confident in them, we'll apply them to the infantile spasms data set, and that will allow us to pull out which children did or did not develop LGS ultimately. And once we have those two different populations identified, we're going to look at the strength of association between LGS or not LGS and certain potential risk factors, like how were the spasms treated? Did the spasms respond to the treatment? What caused the spasms? And what were the other comorbidities or conditions that were going on during this early life period? And we're going to use those factors to quantify the risk of LGS progression, one factor at a time, and then using groups of factors. And ultimately, our goal is to develop a risk calculator for LGS progression. And this we can then take this risk calculator that we've developed and we can do prospective studies where we start with kids that are just developing infantile spasms and we follow them over time to see how well this risk calculator works and to adjust it if needed. And ultimately, we hope that this will pave the way for preventative clinical trials where we are focused on preventing the development of LGS. I hope that a helpful byproduct of this research will be that the development of these reliable computable phenotypes will enable other people to harness the power of big data in electronic medical records to study LGS. And then I just want to say that I'm incredibly grateful to the LGS Foundation for supporting this work, which is a critical part of a larger basic translational and clinical research program that I'm building at Stanford, focused on understanding and better treating the progression of severe forms of pediatric epilepsy, such as LGS. And as you know, many severe forms of generalized epilepsy, like LGS, have genetic causes. So, to develop a center of expertise where we can provide the best care for children and families with these severe forms of genetic generalized epilepsy, I helped found a genetic epilepsy clinic at Stanford. And that positions us to participate in clinical research, such as natural history studies and clinical trials. And then we take the questions, the important questions that are, patient-centered and critical to the lives of children and families that come out of our work in the clinic, in the clinical research. And I take those back to my lab, my basic lab at Stanford, where we use things like genetic mouse models and cellular models to really get into the mechanisms and understand the cellular, molecular, and neurophysiological bases of the epilepsies. And, as a physician scientist, I really think that, the clinical research and basic and translational research are synergistic, and we should be using all of these tools in combination to get to better treatments as soon as possible. So on that note, I'd like to say thanks once again. I'd like to acknowledge my collaborators, Dr. Grinspan, and research coordinators at Cornell and Stanford who've made this work possible. I've had a number of mentors and colleagues on this work, Dr. Worrell, who you heard from, Dr. Ingo Helbig, and Dan Lowenstein. I'd like to acknowledge the input of the Pediatric Epilepsy Research Consortium LGS Interest Group. This is a group of epileptologists that was started by myself and Dr. Erin Warren, who you'll hear from. And I just want you to know we meet every month and we talk about the latest research in LGS, and we have numerous research projects going on, studying LGS from different angles. And this is my basic science lab at Stanford that does the mouse and cellular basic and translational work. So thank you so much for your attention. I really appreciate it.
Thank you.